Well, that
I'd like to thank everyone for joining us tonight for our New Horizons webinar series. Tonight's topic will be spine exposures, and we have assembled a great panelist of speakers. So to start out, I'd like to introduce Dr. Kat Olinger, who's a clinical assistant professor at the University of Iowa Hospitals and Clinics. She's a spine surgeon in the Department of Orthopedic Surgery. And she is going to talk to us about indications, anatomy, and pitfalls, tips from spine surgeons.
Thank you, Dr. Nicholson. It's a pleasure to be here with all of you. I'm going to give a brief overview of the anatomy and tips and tricks, but I'll kind of fast forward a little bit as we want to make sure we have time for everyone to talk about what is really important, at least from an orthopedic perspective, when working with our vascular colleagues for anterior lumbar approaches. I do have disclosures. The relevant one for this talk is that I am a paid Globus medical consultant, but not for any anterior lumbar techniques. We will talk about anatomic considerations. We will talk about anterior interbody fusions, lateral interbody fusions, and then we'll address some pitfalls and some technique tips that you can utilize and put into your armamentarium. In terms of all of you who've never heard the term interbody, that means that a fusion is performed between two vertebral bodies, and it is typically done with a vertebral cage or some kind of implant. Most of you are much more familiar with the anatomy than your orthopedic colleagues. We don't remember general surgery rotations as much as the rest of us, but we do have considerations when we do anatomy or when we do lateral approaches through the thoracolumbar junction. We typically resect the 11th rib and do closure of each layer to try and prevent any iatrogenic hernias and repairing the diaphragm. In the lumbar anterior, like a fan and steel or a paramedian retroperitoneal approach, the same kind of technique. And you can have the arcuate ligament be released and the transversalis fascia also be in consideration when you are dissecting for these patients. I'd like to show you guys some cases because I think it's a lot easier to understand from an orthopedic perspective or from a spine perspective how we approach these patients to give you guys an idea of when you are working with your colleagues, how best to help them. This is a 60-year-old male who presented with bilateral lower extremity back and leg pain, and he has what is called an L5S1 spondylolisthesis, and it tends to be the term isthmic. So I don't know if everyone reminds themselves from anatomy, but isthmic is a Latin-based term that just means the pars or the bridge is broken. And you can see here that it's sliding forward. And when he's standing in his films, there is no connection between the posterior elements of the spine and the anterior elements of the spine. So that's what causes the spondylolisthesis. And a anterior interbody lumbar fusion is the standard of care for these patients. And so we rely on our access surgeons, particularly Dr. Nicholson and I do these together. And this is the patient's outcome. And he had a fantastic recovery and had no complications. Another utility for the anterior interbody lumbar approach is to perform it in a patient with scoliosis. So this is a Parkinsonian patient who came in and he has an extreme flat back deformity. You can see here he has lost his normal lumbar lordosis and he has multiple levels of disc. The black in a CT scan is called vacuolation, meaning there's a lot of abnormal motion and they're severely collapsed. And he had some accompanying stenosis. This is an intraoperative fluoro examination demonstrating the utility of an anterior lumbar approach where you can take a completely collapsed disc and make it to where they have 37 degrees of lordosis, of which the patient did not have at all. And he goes from having no ability to stand upright because he has a flat back to a completely standing upright film and correction of his scoliosis. Complications are paramount, and usually I quote my patients about 4 or 5%. Obviously, there's always a potential for an injury to any vessel that's major near us, but I think that the most common one that we see is a DVT, and that retrograde ejaculation is cited about 0.1% in the population. But then if you go and you look at just studies that cite the retroperitoneal, or so the retrograde ejaculation with a retroperitoneal approach, they can cite it up to 17% in some cases. I think that it is very important that if you're going to use monopolar cautery, that you understand that the lower you go in the sacrum, the higher the risk of retrograde ejaculation, and that we tend to use monopolar cautery if necessary. Advantages over an anterior approach based surgery versus a traditional posterior approach, which when you talk to a spine surgeon, a posterior approach just means a midline longitudinal incision along the back, is that it gives a good vascular bed and bony surface. It has less destructive approach. People recover faster. You're able to restore that disc height and that lordosis, like I showed with the patient with the flat back problem, and that you can reduce spondylolisthesis, like we showed with the first patient. The long-term consequences and treatments are reasonably well understood, and the patients recover very well. The disadvantages is that the body habitus can be extremely limiting. And here at the University of Iowa, Dr. Nicholson and I encounter that on a daily basis. Potential revisions are extremely difficult. I do not revise people through an anterior-based approach if I can avoid it. And that the retrograde ejaculation can be issues with younger males. I think that another utility can also be with a patient here is that you can utilize a lumbar approach, but a lateral based anterior approach in order to address a patient with a collapsed disc. So this is a patient who had L4-5 disc degeneration and pain, and we approached him from a lateral based procedure with a anterior approach. However, we go from a lateral, basically it's almost just right in front of the AIS, and it's called anterior to psoas. And it can be performed from any level in the iliolumbar region from T12 to sometimes S1. And it utilizes angled instruments to access the disc anterior to the psoas. Another patient who came in with back pain and the inability to ambulate and had a history of a nephrectomy, but she ended up having metastatic renal cell. And you can see here that these two vertebral bodies are completely moth-eaten with renal cell carcinoma. And we performed a lateral-based approach once the patient had posterior stabilization to remove the diseased bone to try and cure her from her cancer, but also perform a lateral-based corpectomy in order to improve the patient's mobilization and stabilization. The most things that people want to know about in terms of from a vascular surgery perspective is the difference between a supine and a lateral positioning, tips and tricks. So we're going to start with supine positioning. So this would be for an anterior interbody lumbar fusion. I always place a bump under the sacrum of the patient that will help increase the lordosis, increase the pelvic tilt. So if you have a patient with a high pubic symphysis or high crest, you are increasing your access to that L5-S1 disc space. You need to identify on imaging if the pelvic brim is appropriate to ensure adequate access to the disc space and the angle. You need to obviously avoid over retraction of the vessels. I usually operate with Dr. Nicholson, but if you are establishing this relationship with a spine surgeon, I would encourage you to talk with your spine surgeon and operate with your spine surgeon. Just don't have your spine surgeon walk in and say, oh, well, I can't get to the disc the way I need to get to the disc. We were taught as spine surgeons to operate with our access surgeons to make sure that we're all on the same page. And then there are utilities of specialty instruments. So these two instruments are customizable through the spine instrument company that I use. And what I meant by you can identify the pelvic brim, this is just an anatomic model. If the pelvis or the symphysis is too high and the disc space is too low, it might not be amenable to an anterior-based approach. Tips for lateral-based approaches or the anterior to the psoas technique. Use a slider bed with a break and place the patient's hip distal to the break, meaning that if you break the bed, that you can actually increase the access to the lateral aspect of the spine by breaking the bed and flexing the patient over that. Identify any iliac crest overhang or ribs to see how much space you're actually going to get. Again, operating with your access surgeon is paramount, and usually using specialty instruments can access discs at difficult angles. The two specialty instruments that Dr. Nicholson and I use is a broken ring, which bends over the patient to allow a full 360 retractor-based system. You can see our incision is very small, and we are able to do 4 disc spaces through that same incision. And these are the examples, the CT scan and post-op examples of a patient who Dr. Nicholson and I did, where we did 4 levels all from the right. And thank you very much.
Thank you, Dr. Ollinger. My name is Will Robinson. I'm one of the co-hosts of this along with Dr. Nicholson. And so I just wanted to tell the audience just a little bit about our organization here as we move through the other talks. We have a couple minutes now for any specific questions for Dr. Ollinger. And then at the end, we will have some time where the audience can ask questions of any of the speakers. Ask all of your questions via the question and answer function on Zoom. And so type them in there and please don't be shy. While we're waiting for some, I do have a question for you, Dr. Ollinger. I found it interesting that you said you try not to do redo situations from the front. My experience is that a lot of the referrals from the front are redo situations, usually from a failed minimally invasive technique from the back. Can you comment on that a little bit of sort of what the spine surgeon's view of whether to do, ALIF primarily or as a backup is sort of commonplace, and just how much variability there is in the spine surgeon world around that?
Sure, I guess I maybe misspoke, is that I choose to avoid a revision anterior approach as much as humanly possible, because it is painful for not only us spine surgeons, but for y'all in terms of vascular exposure. I do think that the workhorse for an anterior based approach is in a revision setting, where, like you said, Dr. Robinson, we encounter patients who've either failed fixation from a different approach, from a posterior based approach, or maybe they had very good fixation, but now they have what we call adjacent segment disease, where the levels above and below their fusion are needing to be addressed. And an anterior or an anterior lateral based approach are really good for those situations, because you're reducing the amount of scar tissue that you have to dig through, potentially reduce the amount of maybe even risks of dural tears or other complications with revisions lumbar surgery that you can encounter.
Got it. Thank you. It looks like we have 2 quick questions here. I think you could probably answer before we move on. Do you use neuromonitoring on your cases? And I guess, do you, as a spine surgeon, do you use monopolar cautery to do the actual discectomy?
So I do use monopolar cautery to do the actual discectomy, but when we are dissecting, that is only after I've identified the sacrum, and I do not go below. And so I use monopolar cautery to perform the discectomy from a blood loss standpoint. It's very good. Obviously this is a very vascular area. And so a lot of times if you're doing your annulotomy with a scalpel, you can get a lot of blood back. And I'm just trying to, mitigate that. But if I do use it, I do not go below the level of the sacral ala. And I do not neuromonitor my anterior or iliolumbar cases. Traditionally, we stage these. So Dr. Nicholson and I will do a couple of these, and then 2 to 3 days later, I bring the patient back for the posterior based approach. And anything below the level of the conus, which is typically about L1, I do not neuromonitor. And for these cases, you really want to be able to use relaxation, and it makes it easier for both Dr. Nicholson and myself from retraction basis. And neuromonitoring is traditionally a TIVA based approach, which does not allow muscle relaxants.
Got it. Thank you. All right. We're going to move on to our next speaker, and we're fortunate to have Dr. Mohammed Kassani from Minneapolis. He's with Minneapolis Heart Institute. He's going to give us a talk on the different spine exposure options and avoiding complications. Mohammed?
Hey, Mo, I think you're muted.
Thank you. I would like to thank the Society for the opportunity. These are my disclosures, not relevant to this presentation. I'd like to acknowledge Dr. Robinson for allowing me to share some of his illustrations from his book chapter, as well as anatomic exposure in vascular surgery. As vascular surgeons, we get asked to expose the lumbar spine either anteriorly or laterally. And typically for me, for these patients, I see the patients the morning of surgery. In select cases, I see the patient in clinic if there's a redo situation or in a situation where additional imaging or tests are needed. Vascular complications in anterior exposure are rare, reported between 1% and 3%. The most common injured vessel is the left common iliac vein. L4, L5 disc space exposure is associated with higher risk of vascular injury. Arterial injuries are less common, but in patients who have atherosclerotic disease, aneurysms, or stent grafts, the risk of arterial complication is higher. DVT is reported anywhere between 1% and 5%. And in some reports, they report renal or mesenteric artery injury, especially with the exposure of the L1 to L3 disc spaces. I routinely place a pulse oximeter on the left great toe, and that kind of helps detect if there's any decrease in the blood flow, especially with retraction above L5. Non-vascular complications, ureteral injury, which is higher with redo surgery, nerve injury, infection, hernias, seromas, bowel injury, and lymphedema. This is a report by Dr. Manunga from the MHI group at Abbott, published in 2021, where he reported near 1,200 patients who had ALIF. And you can see here that the rate of complications was very low, less than 5%. And notably, the rate of vascular injury was only 1.4%. And this other publication, where they had over 4,000 patients, the mortality rate was also low, less than 1%. So for me, for these cases, if I'm doing a multi-level exposure, routinely ask the anesthesiologist to place an A-line, Foley to decompress the bladder, routinely use Cell Saver. And there are multiple self-retaining retractors. For me, I prefer to use the Thompson retractor for various reasons. One, they have multiple with various sizes renal blades that are radiolucent. You also have a feature where you can toe in with the retractor, which aids with the exposure in obese patients. I find the use of renal vein retractors and OLIF type retractors also useful. Especially because you can place a light in the retractor, and that aids with visualization, especially if you do want to throw a small OLIF or XLIF incision. I always have on the field a 4 or 5 RB1 proline. I think it's the best needle to control any vascular bleeding in the pelvis. I find the use of cardiac pledge is sometimes useful in controlling venous bleeding. Right angle clip appliers. And I routinely use the ligature to ligate small lumbar vessels, which speeds up the procedure. As mentioned previously, I rarely use any cautery with dissection, and I like to use the bipolar. Hemostatic agents are very useful too, especially for small venous bleeding, which you can pack it and forget about it while you do something else. I typically do these procedures through a midline incision. I think it's more versatile, and you can extend the incision if you get in trouble. For some patients and some some spine surgeon preference, they prefer a horizontal incision. For these, I try to mark the disc space with fluoroscopy before planning my incision. This is an example of a L5-S1 exposure through a lower midline incision. The fascia is incised to the left of the midline, and then we create a preperitoneal plane posterior to the rectus muscle and anterior to the preperitoneal fat. I carry that dissection bluntly till I get to the lateral abdominal wall, and I think it's very important to identify and protect the epigastric vessels as it can cause bleeding and cause fluid collection in the postoperative period. This is a line of dissection. It's important to maintain a retroperitoneal plane throughout the procedure. In some patients, the peritoneum is very thin, or when we do surgery, you can get peritoneal tears. For me, I either fix those with a vicral suture or tuck them away. At this point, you are down to the spine. As far as the L5-S1 exposure, is pretty straightforward. Once you completed that dissection, you only have to identify the middle sacral vessels. You can ligate them, divide them, and essentially expose the L5-S1 disc space. The L4, L5 is a more challenging exposure because you have to, in my opinion, the key to this operation is identifying and ligating the iliolumbar vein, which is the posterior lateral aspect of the left common iliac vein. This vein is connected to a large ascending lumbar vein, and getting into bleeding in that area can be difficult to control. Once I ligated the iliolumbar vein and lumbar vessels, the vessels are retracted to the right of the midline, and the exposure is complete. I rarely place permanent retractors in this area to decrease the risk of DVT or arterial problem. In some patients who have a high bifurcation of the aorta or the cava, it's tempting to dissect the L4, L5 disc space between the bifurcation. I caution people from doing this because you're placing retractors on both iliac veins in opposite direction, and that can cause really a vascular catastrophe. This is an intraoperative picture of mobilized left common iliac artery, and you can see two iliolumbar veins on the posterior aspect of the common iliac vein. For lateral exposures, those are typically performed through smaller incisions, and we're asked to do the same exposure. I think it's key to have a good positioning, use fluoroscopy to identify the optimal place to make your incision. A lot of vendors have different retractors. One key to minimize the risk of bleeding is not to overstretch the vessels, as if you get into bleeding in this area with small incisions, it can be very hard to repair. As far as risk factors for complications, they are listed here: obesity, prior procedures, radiation, arterial disease, prior spine instrumentation, and infection. And I'll show some examples here. I wanted to highlight the different patterns of obesity between males and females. You can see the picture here on the right. The majority of the fat is visceral fat, and this exposure in a deep patient can be proven to be challenging because the majority of the fat is visceral. Well, when you notice with the female type obesity, the majority of the fat is subcutaneous fat with minimal amount of intra-abdominal fat, making the exposure easier. Looking at the imaging studies is very key prior to an operation. You can see here the iliolumbar vein. In this situation, a small, a short iliolumbar vein with multiple tributaries, and knowing that in advance can help avoid bleeding complication. In Dr. Manunga's paper, he described several variants of iliolumbar venous anatomy. The most frequent are A and D, where you have multiple tributaries of the vein. And the recommendation is to ligate and divide each branch individually to minimize the chances of bleeding. This case I did last year, anterior exposure for a patient requiring L2 to S1. It was important to know beforehand the patient had duplicated IVC, as you can see here with the big IVC on the left side. And knowing this in advance helped me plan the operation. And instead of going left-sided approach, we approach it from the right side. Patients with atherosclerotic disease and who have balloon expandable stents are at risk of stent complications. You can see here patient with bilateral iliac stents and a crushed left iliac stent after anterior exposure. Patients with discitis and osteomyelitis are also challenging, as the tissue planes can be fibrotic and the dissection can be difficult to perform. Another consideration: a patient with osteophytes can, tempt the vessels and make mobilization more difficult. For these kind of patients, I tend to mobilize the vessel more to minimize the traction injury. As mentioned before, prior spine instrumentation, this is a perfect example of a patient who failed fusion from a posterior approach requiring revision anteriorly. And although there is no hardware anteriorly, I find those cases to have more fibrosis and scar tissue. Finally, this is a case where the patient who has a large common iliac vein and multiple tributaries. We encountered bleeding during the case, which was very difficult to control. So we accessed the common femoral vein, and given the size of the vein, we treated with a reversed iliac limb, and the patient did okay. So having endovascular bailout maneuvers can be helpful. In summary, it's important to review the imaging and pay attention to the anatomy, have the correct instruments and tools to perform your exposure. A good line of communication between the access surgeon and the spine surgeon is also important. I feel for success, patient selection is key. And finally, safe exposure is the best exposure, and don't compromise that on the size of the incision or speed. Thank you.
Thank you, Dr. Koswani. I was wondering if you could talk a little bit about what imaging you prefer to have prior to the operation. A lot of patients seem to have already had a CT of the lumbar spine, but do you go ahead and get a full CT abdomen pelvis before you do these? And then I was also wondering if they've had prior iliac stents or really heavy calcifications, or I guess what kind of things would make you not want to do an anterior approach?
Yeah, so to answer your first question, typically those patients who have a focused CT or MRI of the lumbar spine, it's really like zoomed in on the spine and you can't see the other structures. I don't routinely ask for other imaging unless there's something different, like had a patient recently with a VP shunt, or a patient who has a gastric band with a port in the anterior abdominal wall. Other patients I ask for imaging, those patients who had a prior hernia repair, I like to review their op notes, and if they had a previous transperitoneal hernia repair, I also ask for imaging for those patients. With regard to your second question, this case I got involved in, it was a different exposure person. But I think, there are two options, either, plan to perform balloon angioplasty and fluoroscopy at the end of the procedure. I think the problem with that is you can't really give heparin to a patient who just had spine surgery, or discuss with the spine surgeon to pursue either a posterior approach or transforaminal approach.
Thank you. We do have one question in the chat, and I will just throw that out there. And the question is, does anyone in the panel use fixed retractors at L4-5? And if so, how long do you allow the vessel occlusion before releasing the retractors?
I personally do not like using fixed retractors for L4-5, just to make sure that there's flow through the vein and decrease ischemia to the lower extremity.
Thank you. So I'd like to introduce our next speaker. It's Dr. Courtney Morgan. She's from the University of Wisconsin and is assistant professor of surgery there. And her talk is entitled "How to Start a Partnership with a Spine Surgeon."
I also started muted, but thank you for the opportunity to share this topic. I think this is an important topic sort of in thinking about spine surgery. And I've sort of recently started a partnership with one of our spine surgeons, and I'm sort of going to talk through that process. So I have no disclosures. So we're going to talk about finding a spine partner, navigating the learning curve, managing the logistics involved with working with your spine partner and growing the practice. So I think the first question is, why would you want to start a partnership with a spine surgeon? I think a nice thing about doing these spine exposures is these patients are generally pretty healthy and they actually have really good outcomes. So sort of unlike some of our typical patients, it's actually really nice to get to operate on a patient who the next day feels totally better and is probably going home. So I find it to be really rewarding, and it's an opportunity to do something a little bit different. I think it's also a good opportunity for our trainees, so those of us who are at a training program, to not only expose our vascular trainees to the exposure, but to the anatomy that they're going to be learning by doing the exposure. And then in addition, working with the spine trainees and helping them sort of develop a relationship with a vascular surgeon so that when they go out to their own practice, they sort of know how to navigate that. It's also not a bad place to get good reimbursement in RVUs, and I think we're talking about that a little bit later. Referrals is another reason to do that. So a lot of our patients that are seeing spine surgeons have maybe a mixed claudication picture. So it's nice to have somebody to help you rule out neurogenic versus arterial, and I think there's going to be a lot of referrals back and forth. And then finally, maybe you even get to use some of the fun orthopedic tools, which we don't often get to use unless we're doing amputations. So how do you find a spine partner? I think the biggest thing to know is they're definitely out there. So especially most newer spine surgeons, when they're trying to establish a practice, once they really want to find a good partner. And once you prove yourself to be a reliable partner, they're going to want to keep working with you. So there's a lot of folks out there. And I think just asking around and getting to know people is a great way to do it. So there's definitely availability. And then once you do establish yourself, the ways to sort of continue working with somebody is they're looking for somebody who's interested. So, being able to talk through cases together, somebody who has interest in innovating, learning new skills with them, I think is a big key. Somebody who's available. If you're too hard to schedule with, you're not going to be an appealing partner to work with. So I'll talk a little bit more about this in logistics, but having the availability or specific set-aside availability, I think is key. Willingness to innovate. And I think sort of a mutual level of desire for innovation, I think is important when you're looking for a spine partner. And then obviously you need to have skill, especially early on. It's best to avoid complications. I think that's not a great way to get asked back to the partnership. So, and I'll talk a little bit about the learning curve there too. So in terms of navigating the learning curve, we did a study here at Wisconsin, sort of looking at starting a spine partnership and looking at the first 25, like basically the first cases versus like later on cases. And I think one of the keys is to start with some more simple, straightforward cases, do some L5S1s, BMIs less than 35 to get comfortable working on the exposure itself, but also working with your surgeon. I think I completely agree with Dr. Ollinger about you want to operate with your spine surgeon. And I think as you develop that relationship and learn how you work together in the OR, it's helpful to be doing more kind of straightforward cases. I also completely agree with planing your incision using fluoroscopy, especially when you're starting out, but I would say this is something that's helpful to do every time. It's according to our study, it can be helpful to collaborate with an experienced surgeon. I think the time where the most complications occur are usually in the first 25 cases. Often this is not necessarily going to be an option, but at least having someone that you can call up and say, hey, can I review these images? Is this a good idea? What are some pitfalls I'm going to need to look for in this case? We've actually found a lot of benefit of observing surgeons who do this a significant amount. So being able to go and see a spine vascular team that does just an absolute ton of these to learn ways to innovate, to work more efficiently, to work faster, to be able to do more complicated cases. I think you can really learn from collaboration, both on the spine side and the vascular side. And then if you have the availability to work together with your spine surgeon in the cadaver lab to sort of, again, innovate your technique. I think managing the logistics can actually be really challenging. Schedule availability is probably one of the hardest things to sort out. So what I do is I actually know what days my spine surgeon has for her OR and pick however many per month that I set aside. And the advantage of that is that she or her scheduler can actually go ahead and schedule cases that day without having to call me up and ask me and see if I'm available and talk to my scheduler. So I think depending on what your practice looks like, and sort of what your OR time looks like, it can be helpful to have some sort of a system that can be done relatively seamlessly. Oftentimes, at least in our case, this is done during spine's OR time, but I think knowing whose OR time you're going to use and how that's going to work is important. And then in terms of optimizing that time, if you can get sort of a multiple room with optimal turnover, if you're doing both anterior and posterior on the same day, that is something that you can work on too. Figuring out which trainees you're going to work with is another aspect. So is it going to be vascular trainees? Is it going to be spine trainees? Is it going to be both? What levels are they going to be? Because I think, especially when you're at a teaching institution, it's important that they're getting that experience too. We've found that working with our spine fellows, so the vascular attending with a spine fellow is actually a really good combination. So they get comfortable with the exposure when they go out. And then also figuring out pre and post-operative care and who's going to manage complications. So these are all things ideally you have decided ahead of time, and sort of have a plan for that. And then finally, marketing and growing the practice. So once you've found a spine partner, when you're sort of marketing your practice and showing what you have, the patients want to feel like they're being taken care of by a team. So even though as vascular surgeons, we don't really know how to do the spine part of the operation, we shouldn't have to, talk about everything, but I think knowing the basic steps of the procedure, because if you see these patients in the office ahead of time, especially, they're probably going to ask you more about the spine surgery than they are about the vascular surgery part. So it's helpful to be able to at least know a little bit of the lingo and sound like you know what you're talking about. I think we found that if you put out market material, so like videos or websites or things like that, usually there's a pretty good chemistry between you and your spine partner once you started working together. So showing that is something to really highlight. And then thinking about what demographics you want to target and sort of using those as example patients. I think as you're building your practice, it's also important to consider doing a market analysis. You don't want to, take volume away from your spine partners. So sort of figuring out where the two of you will fit in to the current market, and if there's an untapped market that you can look for. So in summary, it's a great opportunity to make new friends. We get to work on healthier patients with good outcomes and a good opportunity to grow your practice.
Thank you, Courtney. Great talk. We have a couple questions. They seem to all be coming from Loyola. Dr. Bernadette Olivola and Dr. Carlos Pichara actually have the same question on the Q&A. They want to know, what is your policy or procedure or practice for seeing patients preoperatively and postoperatively? Why don't we give Courtney the first shot at it and then go around the panel?
Yeah, so when possible, I actually do like to meet the patients in my clinic before the day of surgery. It's usually a relatively fast visit, but I think it's a good opportunity to meet the patient, look at their belly, see if they have any other incisions, talk with them about where you're going to make your incision, make sure they're comfortable with that. A lot of times they really appreciate that visit if you can fit it in, because they're probably going to be nervous. So knowing their whole team that's going to be working with them, I found that to be helpful. Logistically, again, it doesn't work for everyone, but that's what I've been doing. And then in terms of post-operative issues, one of our challenges is that the spine operations happen at a different hospital than sort of our main hospital. So we aren't there to round. So we have an agreement actually with the spine surgeons that as long as everything is straightforward, they usually see the patient on post-op day 1 and send them home. And then I only see them if there's a complication like a wound problem or something like that. So.
Got it. How about the others on the panel just quickly for pre and post-operative visits?
For me, for preoperative, I see probably 90% of them preoperatively, and like Dr. Morgan, none of them postoperatively unless if there's an issue.
For most of my patients, I meet them the morning of surgery in the pre-op area and typically introduce myself, and they know there's a vascular surgeon involved, and I discuss the complications with them. The spine surgeons I work with, we've worked long enough with each other that they know when to send the patient, or even just give me a phone call. Is there imaging you want? Do you want a left ureteral stent? Or this patient had multiple operations, and I see those patients in clinic.
Got it.
I send all my patients to Dr. Nicholson for further evaluation perioperatively, but we also host vascular grand rounds with our spine council. So my residents and her residents can hear our thought process of when we're going through these patients, of why we're directing care to each other. And I see them all post-op unless there's an issue. Our residents co-manage them while they're together. We typically defer a diet to the vascular team, and then we take care of everything else.
Got it. Great discussion. We do have one question here from the Q&A that's really a reimbursement question. So why don't we get to Dr. Brian Kuhn's talk, and then we'll have to make sure to get back to this question about potential for direct contracting with hospitals, but maybe we'll follow that up with after Dr. Kuhn's talk, and he's going to speak on billing, coding, and the business of spine exposure. Brian?
Can you guys see my slides? I'm trying to.
Not yet.
You can see him or not?
No.
No. So I hit share screen, share.
There you go.
All right, thanks, guys. Sorry about that. So I'm going to talk to you guys about billing, coding, and the business of spine exposure. I'm from Cincinnati, Ohio, and my practice is maybe a little bit unique in the fact over the last 12 months, this has become my entire practice. And so I'm doing this every single day of the week, multiple times. These are my relevant disclosures. I have no royalties with any of these, but do training and teaching for all of them. And so my talk has some overlap with Courtney's as well. And so there's no doubt that medicine is a business, whether we like to admit it or not. And on the current subject, the product of our business is midline exposure to the lumbar spine. And so the consumer of our product is really twofold, like we've talked about. It's the spine surgeon as well as the patient themselves. And so when you're trying to sell your product, you really want to know what you're talking about. And so when we're there and we talk about our product, we want to be brief, we want to be bright, and then we eventually want to be gone. So you want to know what to talk about with the spine surgeon and what they want. And so when you're selling a product, the book called The Spin of Selling says you really can't be an effective seller of your product until you know what your audience is looking for. And this is one consumer of our audience. And spine surgeons are all over the board as far as, you know, their value of the anterior column. Some of them may use it all the time and believe in it. Some probably don't use it, but understand that there's relevance to it, or might see it as highly morbid. And there's other surgeons who may tell you that they don't need it at all. And so, as we've talked about a little bit earlier, you need to know some of the impact of the anterior spine space. And Dr. Ollinger touched on this as well. But an ALIF gives them excellent height restoration, which gives them great indirect decompression to the nerve roots and can sometimes avoid posterior surgery for them. And so an ALIF also is excellent for hyperlordosis and sagittal alignment for the lumbar spine. All of these things have become extremely important as they understand the biomechanics of the lumbar spine. And so the fusion rates for an ALIF at 5'1", really an ALIF is the king. The fusion rate is the highest, and the goals of the surgery really can be accomplished the best through an ALIF. And so there can also be some sticking points. I don't know a spine surgeon who doesn't value money and doesn't value time. So if you can get to the lumbar spine quickly, efficiently for them, they're going to be more productive, and so are you, and they're going to sleep well at night with that exposure. And so we do have some common objectives. One of the things that we're going to touch on is money. And so obviously we're doing a surgery where there's going to be co-surgeons now, so there's going to be some sharing of reimbursement that's involved. And as Courtney talked about, these are logistical issues because most of these spine surgeons are very busy. They have a busy schedule, and now they have to try to accommodate another surgeon. And then you really don't want to be late. When you're late, they just won't call you if you're late all the time showing up to these cases. So show up with a smile, be available, and if you get them to the lumbar spine quickly, they'll become some of your best friends. Some of them have some reservations with it. Some of them say, I don't want to reposition the patient. It takes too long. I'm good at doing T-lifts, and I can get all the lordosis I want. And by the way, well, maybe I haven't done one in quite a while. So a lot of them have some preconceived notion about the morbidity associated with an ALIF. For a long time, these were done through big laparotomies. They were done transperitoneally. The vascular injury rate historically was sometimes as high as 20%. Well, no wonder nobody wanted to do those. Nowadays, we can do a minimally invasive retroperitoneal, and as discussed earlier, with a very low vascular rate. And some people out there just tell you, that we don't need you. I do it myself and really do it without complications. So those consumers are all over the board, but that's kind of what you can run into when you interact with spine surgeons. And once you get past the spine surgeons, your second consumer, most importantly, as being a doctor, is a patient. And it's okay to market yourself to the patients as being a spine access surgeon. It didn't hit me until, a year or two ago when a patient came to see me for the access and said, I almost didn't even come to see you. My spine surgeon said I had to see you, but I looked you up on the internet and it just said you do carotids, you do aneurysms, you do peripheral vascular disease and varicose veins, and it didn't mention anything about doing spine surgery. So I almost didn't even come. And so you definitely need to have these on your websites, because that's the first thing patients do is they'll Google you before they even come see you in the office if you see them. And it's okay to market to them when you talk with them that nowadays we do this minimally invasive. There's specific retractors set up for these cases. Learn how to use these techniques, how to use these retractors, patients like that. And there's a huge value to the community when you're doing these large spine surgeries, as we discussed earlier, through these minimally invasive approaches. And so that's just kind of some of the business of it, some of building kind of these relationships, which is crucial. And I'm going to go into just some coding 101. There really aren't too many codes that are needed for this case. But here they are. So an artificial disc replacement is the top one. The two main ones that you're going to probably use are the 22558 and the 22585. So that is your first level. If you're doing an ALIF, it's the 22558, and the additional code, or for the additional level, is the 22585. Now, as you can see here, those are your initial cases, and it's going to be a co-surgeon case. So you'll be a 62 modifier, and we'll go over that on the next slide. But look at all these other codes that your spine surgeons can put in. So if there's a pseudoarthrosis and they remove a T-lift, there's an extra code for that. When they put the cage in, there's an extra code for that. If they put a plate on the anterior space, there's another code for that. So no matter how this breaks down, they're going to make more money than you do on this case. But that's what I pretty much make all my spine surgeons include me as assistant surgeons for any of these other additional codes that are used. And so, Medicare, we talked about a 62 modifier. Both the spine surgeon and the vascular surgeon need to list this as a 62 modifier case. If you do and they don't, they're going to get 100% and you're not going to get paid. So it is very, very important that both surgeons list this as a 62 modifier co-surgeon case. They do realize they're giving up a certain percentage of that, because as a co-surgeon case, you get 125%, but you still both make out. Same thing when you use an assistant surgeon for the 80 modifier. Both operative notes need to say that you were there, that you assisted, and you helped out. I can't tell you how many spine surgeons I tracked down ruthlessly, telling them that their notes, their templates have to list me as the assistant surgeon when they place these cages. Because if you're there and you're participating, you should get reimbursed. And then there's a 22 modifier that we could all probably aware of for very difficult cases, reoperative nature, a lot of blood loss, and that allows for an increased 20% allowable of reimbursement for these procedures. And so it goes to definitely need to harp on this, is that it has to be included pre-op. So there's a prior authorization that goes into these cases and into these codes that you have to be listed on there, and it has to be listed clearly, because if you're not listed preoperatively and you're not in the prior authorization, you're not going to get any pay. So these would be the codes that I would use: the 22558 for the initial code, 22585 for the additional, and then for two cages that were placed at 4.5 and 5.1, this is how it would break down after 62 and 80 modifiers. and almost 20 RVUs for that case. How does that compare to something else we do? Somewhere between a TCAR and a carotid endarterectomy. So not doing too bad, but that's kind of where we live. One of the things that I got burned on when I was starting to do these is time consuming. So the spine surgeon billed it as a lumbar corpectomy, didn't include a 62 modifier as a co-surgeon. My coder coded it the straightforward F at 22558. So when all the payments went out, I got nothing. The spine surgeon got a tremendous amount of reimbursement for a very difficult case. So make sure you go and sit down with your coders and they know how to code this. And so I haven't been to this, but I know the SVS every year offers a reimbursement and coding workshop in the fall. They do cover this from my understanding. And some of you might have even seen this open forum level letter that was sent to the SVS reimbursement and coding committee about, you know, some of the struggles for these reimbursements for these ALIFs, and especially, you know, in private practice, and that there's not a separate code for the exposure. The exposure code is built into the 22558, which is the exposure, the arthrodesis, as well as the closure. And so some of the vascular surgeons are, you know, frustrated that they're there longer than the spine surgeon is. And despite that, the spine surgeon is still making more money than what we are on these cases. It's kind of the reality where we're at, but the big push was to try to see if there's any way the SVS can push for a separate code for the access for these cases. And with that, thank you for your time. And as vascular surgeons, it's awful cool to see these and sometimes deal with these complications. But it's also some of the most grateful patients I've had are those who I do ALIFs on and relieve their pain. And sometimes it's nice to sit down when you do surgery as well. So, but not all cases are easy. So thank you for your time.
Great. Thank you, Brian, for that great talk and overview. Let me ask just one point of clarification. Can you review those other codes other than the first fusion level code and then the additional level, and clarify which ones are eligible for a co-surgeon and which ones are eligible only for an assistant? I think that would
So
be
here's the coding 101 that I have up. So none of my surgeons do artificial disc replacements for the lumbar spine, but that would be a 22857. That is the 62 modifier that you can use. The 22558, the 22585 are for 62 modifiers. And then the bottom one, a corpectomy for the 63090 is also available for 62. The other ones for the removal of T-lifts or any other spine device, insertion of the cage, and if they're still putting plates on, those are available for 80 modifiers.
Got it. Got it.
Brian, quick question for you. When you're assisting with an OLIF or XLIF, do they put you as a co-surgeon or as an assistant?
Co-surgeon.
We do have one question that's been up there for the audience for a while, and maybe we'll give Brian first stab at this and then open it up for knowledge of the rest of the panelists. So the question is whether you all have had any experience with direct contracting with a hospital to provide spine. So this surgeon currently does 4 to 5 cases a week. They want to do more, but this, as you mentioned, Brian, the spine cases take some time and sometimes don't reimburse as much as things that can be done otherwise, especially in an OBL setting. Do any of you have any experience or knowledge about a professional services agreement for spine services with the hospital that's been set up rather than a case by case, as an alternative, reimbursement system to what you've described, Dr. Kuhn?
I'm aware of one, and I've been approached by one, but I haven't gone down that path. I've got plenty of work to do here, and I don't need to travel to remote places. And so that's where I'm aware of this occurring is, hospitals in need that directly contract through a third party who can then you can get reimbursed fairly well for your time and for doing these cases. But I've not done it, but I'm aware of it.
Got it. Dr. Ollinger?
We do not have contracts. We are much like Courtney is. We are a university hospital. I did train in a private-demic model in residency where there were vascular surgeons who were contracted by the hospital to allow for access when necessary. But honestly, I think that that is just they were hospital employed vascular surgeons. Obviously, I'm not one, so I won't speak for them, but they obviously had a agreement with the hospital and that our surgeons were private practice guys who just utilized their services because they were at that hospital. I'll echo what Brian said, that we always co-surgeon, Rachel and I, and it's built into your Epic. So if you are utilizing Epic and you have pre-procedural, pre-populated things, it always puts Dr. Nicholson's name as a co-surgeon under, a separate heading. So it says first surgery team, and it'll put me and then the rest of the people who are with me, and then it'll put her as co-surgeon and then anybody who's is associated with her. And so that 62 modifier is automatically built in for our coders because the Epic puts it as co-surgery every time.
Yeah, this is a big issue. It's a big issue. I'm involved with the North American Spine Society with access, and we brought this up at a committee meeting last year with the coding committee because of all these issues. I mean, it is a headache, and especially if you're in private practice, it's even more of a headache that I don't even fully understand. But from what the coding and the coding committee said, from their standpoint, obviously, anytime you try to add new codes, it's very difficult. And then whatever value goes into those codes, it gets taken away from others. And they also mentioned that the number of anterior reconstructions has gone up so much that they think within the next 2 years, Medicare is going to reevaluate the value for these procedures. So
I have also heard that. I am on a committee for the North American Spine Society, and that has been a discussion. I think for all of the vascular surgeons in the room, I would screenshot this. I would show this to your spine surgeon. I mean, most of us are actually really, really good about dictating. I even dictate the codes for my coders. If you're coding at a large university hospital where you don't personally have a good relationship with your coder, I think that it is paramount to say, procedure number 1, L5S1, anterior interbody arthrodesis 22558. That is literally how I dictate, and and that's how I was taught in fellowship, and that's how my fellowship director did it. And it was ensuring that the coders know that which code is supposed to be associated with which procedure. I have never dictated the modifier, but like I said, Epic already auto populates Dr. Nicholson as a co-surgeon, so I'm not sure if I would require that. But that is a good way to get your spine surgeons to code appropriately as well, is to have them actually dictate the code following the description of the procedure that they are doing.
I have one other question for the panelists. I'd like to get everybody's experience with oblique and lateral exposure. So ALIF versus either OLIF or maybe even helping with XLIF. It's kind of hard to get a gauge nationally on what's going on here. I'd kind of like to hear everybody's thoughts about, do you participate in the decision to do a standard ALIF versus some sort of oblique or lateral exposure? Or do you just sort of provide what the spine surgeon desires? Number one. And number two, talk about the learning curve a little bit and sort of what percentage of your practice that those oblique or lateral exposures have become. I'd like to just get everybody's experience with that. Maybe start with Mohammed and then go from there.
There are 2 surgeons that I work with that prefer to do OLIFs. One of them actually does it by himself, unless he's going, L1, L2, and there's special anatomic consideration. And the one surgeon I participated with all his OLIFs. It was definitely a learning curve. It wasn't hard. As long as you plan your incision right and you're on the right plane, you get right down to the spine, anterior to the psoas muscle. I'll be honest with you, for me, it's one of my least favorite exposures because I rarely can see what they're doing because it's done through a smaller incision and it's very anxiety provoking sometimes. I talk to them if we're going, L2, L1, big obese patient, it's going to be an extensive exposure for anterior. We kind of sit down and have a discussion whether, approaching laterally would be more appropriate.
So I'll go next. So they usually come kind of with a plan, what they want to do, what they kind of think they want to be done. But certainly if there's something I see, we'll modify the approach. If they want to do an ALIF and the whole abdominal wall has been reconstructed with mesh, I'll say, well, this is probably, let's go oblique. There's probably some window out laterally that we can do just for example. So yeah, it is definitely a team game. It works best when there's good communication and good teamwork for sure. As far as the laterals go, it's still probably 5% or less of what I do in my cases. There is some anxiety with kind of that learning curve there was for me because we never operate in the lateral position. And so I had some anxiety with that, but then once you do it, and now that I've done it, I actually love doing them. It's a 10-minute case to get down there and place the retractor. I really enjoy doing them now. Positioning the patient's not the most fun, but you get used to it and how you do it. And once you get a cadence down, it actually works quite well.
Yeah, I primarily do just anterior. We haven't done much in terms of oblique and lateral, but for all the patients that my spine surgeon wants to do, she'll actually send me sort of a patient message with that patient. I'll take a look at the images, sort of give the go ahead, say yes or no, I think this is a good idea. So there's definitely sort of mutual input in terms of making a decision on what's appropriate for them.
I'm very similar, like I said earlier, but Dr. Nicholson and I specifically host a grand rounds with both of our residents and go case by case so that they can hear why I'm verbalizing a specific access would be a nice way to approach a patient. And then Dr. Nicholson can weigh in on if the approach is appropriate or not. She helps me with all of my lateral based approaches as well as our anterior based approaches. The reasoning is that we actually do a right-sided oblique approach and we choose to take down the iliolumbar vein and look at the vein the entire time, which makes it safer from my standpoint that I'm not overreaching the disc space and potentially causing an iatrogenic vein injury that I can't see from a left-sided approach. Obviously the patient has to have acceptable anatomy for such a thing, but Dr. Nicholson and I have done plenty of lateral based L2 to S1 approaches all from the right, and it's really helpful for coronal plane deformities and scoliosis.
And well, I'll go back quick to one of the earlier questions as far as the fixed retractor at L4-5. I use it. So I use fixed retractors if I can at every level. At 4-5, that's where the pulse ox comes into play. If I notice the pulse ox drops off, a lot of times if you look at anesthesia, their blood pressure may be 90. And if you just drive their blood pressure up to 140, you'll see that pulse ox pop right back up. And for some reason, if it doesn't, every 15 minutes, I'm kind of releasing that blade to kind of get reperfusion back and then resetting it for them if it takes that long. So that's just my opinion, just how I do it.
I agree, Brian. We've had a couple where in the literature on the spine side is 15 minutes. So set-based retractors with left toe pulse ox, and our pulse oximeter is right next to their hand pulse oximeter, keep their maps up. So mean arterial pressure of 80 or so, and then release it at 15 minutes.
I'd like to just take a moment to thank all of our panelists and my co-moderator in this endeavor, and also thank the Midwest Vascular Surgical Society for the opportunity to do this. I think this webinar series has been very helpful, and hopefully the viewers have found it helpful as well. And I appreciate everyone logging in and joining us tonight. So thank you so much.
Good night, everybody. Thank you.